This video is available in 21 languages. यह वीडियो 21 भाषाओं में उपलब्ध है. To change the audio, go to settings, click on the audio track and choose your favorite language. ऑडियो बदलने के लिए सेटिंग में जाएं, ऑडियो ट्रैक पर क्लिक करें और अपनी पसंदीदा भाषा चुनें.
Human bipedal locomotion is defined by its metabolic efficiency. Every stride relies on precise structural engineering to minimize the energy required for every step. The standard orthopedic model defines the hip as an inherently stable ball and socket joint, secured by deep bone and powerful muscle groups. But clinical data reveals a growing problem. Despite this inherent stability, non-traumatic hip micro-instability is rising, specifically following hip arthroscopic procedures. This trend stems from a specific medical consensus that the anterior hip capsule is a passive check-rein designed only to prevent hyperextension of the leg. This static model is an oversimplification. Relying on it during surgery compromises patient recovery. Addressing the micro-instability crisis requires a new framework. By combining high-resolution MicroCT morphology with in-silico kinetic modeling, we can define the anterior capsule as a dynamic engine. The mechanical challenge of walking begins with the single-leg stance. When weight is borne on one leg, the center of gravity shifts away, creating a downward turning moment. To keep the pelvis level, the abductor muscles must generate a massive counterforce, dictated by the lever arm ratio. In a standard walking stance, these joint reaction forces routinely reach 3 times the total body weight. Biomechanical principles dictate that these repetitive, high-magnitude forces drive the biological adaptation of the surrounding bone and soft tissue. A purely static muscular model fails to explain how the joint manages these specific loads without experiencing structural failure. The iliofemoral ligament, or IFL, provides the necessary structural resistance. It is the strongest ligament in the body, with a tensile strength exceeding 350 newtons. Traditional textbooks illustrate the IFL as an inverted Y originating from a simple, thin Meniere's attachment point on the pelvis. High-resolution micro-anatomical studies show that this linear model is incorrect. This photograph reveals the true origin point on the anterior-inferior iliac spine. The star marks a broad, specialized anatomical footprint. The schematic clarifies the scale, mapping an osseous attachment zone significantly wider than surrounding muscle origins. MicroCT data confirms that this footprint is a structural adaptation to heavy loading. The bright zones of cortical thickening correspond to the highest levels of tensile stress. Looking at the tissue level, we can see the capsular fibrous layer integrating directly into the bone. Histological analysis identifies calcified fibrocartilage at this boundary, a biological marker of continuous, high-intensity mechanical stress. The specialized geometry of the AIIS footprint serves as a structural adaptation designed to manage the massive tensile loads generated by the leg. The IFL is not an isolated structure. Its bands blend into the deep aponeuroses of the gluteus minimus and iliopsoas muscles, linking the capsule directly to the muscular system. During hip arthroscopy, surgeons often detach this joint capsule to access the labrum. An instrument sweeps across the anterior capsule, violating this crucial anchor point. Severing this fibrocartilaginous footprint without repair removes the structural tension required for joint stability. This structural damage is the mechanism behind the rising prevalence of post-arthroscopy hip micro-instability. Treating the anterior capsule as a disposable surgical window ignores its mechanical integration with the active muscular system. To understand the impact of this loss, we have to look at the kinetic function of the joint during movement. Because the IFL shares the same moment arms as the hip flexor muscles, it likely provides mechanical assistance during the gait cycle. A musculoskeletal simulation using the Anybody modeling system allows us to track these forces during straight-level walking. In this model, the superior and inferior bands of the IFL are represented as mathematical springs, placed at the precise anatomical origin and insertion points. The simulation first calculated the mechanical work required by the iliopsoas and sartorius muscles when the IFL is absent. When the IFL spring strength is engaged, the workload required from the iliopsoas muscle drops by exactly 50%. As the hip extends in late stance, the IFL stretches, storing potential kinetic energy within the ligament. During the swing phase, that energy is released as the ligament recoils, passively pulling the femur forward and reducing the active flexor muscle demand. The anterior hip capsule functions as a passive kinetic engine that slashes the metabolic cost of locomotion in half. MicroCT morphology shows the IFL is built for structural loads, while kinetic modeling demonstrates that these loads drive energy-efficient movement. An unrepaired capsulotomy results in an immediate loss of passive spring tension, doubling the workload on the flexor muscles. This increased metabolic demand leads to premature muscle fatigue and altered gait mechanics, eventually resulting in joint micro-instability. The iliofemoral ligament functions as a dynamic, energy-storing tension network. Meticulous anatomical repair of the capsulo-ligamentous complex maintains the energy-efficient mechanics required for human bipedal locomotion.